I would now like to introduce our key speaker, Dr. Kelly McCants. Dr. McCants is the acting executive director of the newly formed Norton Healthcare Institute for Health Equity and serves as Norton Healthcare's medical director of advanced heart failure. Growing up in Jacksonville, Florida, and Tuscaloosa, Alabama, Dr. McCants said he drew his inspiration from his mother and his older brother. He's the first physician and only the fourth college graduate among 54 members of his extended family. His brother, now a police captain, and his mother, who went back to school at age 40, were the first and second college graduates. Dr. McCants attended Tennessee State University in Nashville before going to Meharry Medical College, also in Nashville. He completed his internship, residency, and fellowship all at the University of Louisville. He returned to Louisville after a stint at Atlanta, Georgia's very prestigious Piedmont Hospital, where he was the director of cardiac transplantation. Dr. McCants has a true passion for addressing health disparities by identifying and removing barriers that prevent people in underserved areas from receiving health care that they deserve. I'd like to thank you very much, and please join me in welcoming Dr. Kelly McCants. Kelly.
Thank you. Thanks, Dr. Frazier, for that introduction. I really appreciate it. And thanks to the folks that put on these educational activities. I think it is truly needed. And for me, it's an honor to be able to talk to you guys about something that we see every day, which is hypertension. But what I want to do is show you an unusual presentation of subclinical hypertension. And as we move through the presentation, I'll be honest, it caught me by surprise. And I think it's something that we see on a day-to-day basis that sometimes escapes us. And so as we move through this presentation, just think about your differential diagnoses that may come from a patient that presents to your office. And we can go to the next slide. So these are the objectives for today. Number one, to recognize subclinical hypertension as a substrate for myocardial dysfunction. We know that patients sometimes have a long history of hypertension before it's clinically recognized. And as providers, when that blood pressure is a little bit borderline, we don't always get alarmed, but I can tell you in certain patient populations, we should probably pay a little bit more attention. The second is to understand how hypertension affects and can be accelerated to a cardiomyopathy, particularly in African Americans and people of color. And then finally, to understand the diagnostic workup for in-organ damage as it relates to a cardiomyopathy. I think that will mainly be a review, but we have some interesting pictures to show. And this is a case that actually I presented for the American Heart Association last fall. And I think it is clinically important and has some relevance for the providers here at Norton Healthcare. You can go to the next slide. So first off, this is a case of a young male, 37-year-old African-American male who presents with chest discomfort. And right off the bat, when you see a young person presenting with chest discomfort, it's either real or not real, at least in our minds, but we get a little bit concerned when this patient presents with classic chest pain that's radiating to the jaw, down his left arm, and associated with palpitations. And that's almost right out of the textbooks for an acute coronary syndrome. And rightfully so, the next step in this patient management, you can clearly see here. But I think there's a few other clinical things that we need to draw some attention to. Number one, he has a classic presentation of acute coronary syndrome. But when we look at his BNP or his creatinine, and we start to look at what's happening at the kidney level, he's already started to spill protein in his urine, which again, that in-organ damage means something that's been going on for quite a while. When you look at the blood pressure at the time of presentation to my office, his blood pressure is 140/80, pulse was 70, and 140/80, you know, we recognize that it's a little bit high according to our treating targets. but it's certainly not something that we would be extremely alarmed about. But when you go back in his medical history and you look at the progress notes and clinic notes from the other providers that saw him before, you'll see that over a 2-year span, he's had just this subclinical hypertension that went a little bit ignored, and to the point where when I saw him, he was on no medical therapy for his hypertension. And so when you see these blood pressures over a 2-year period, 130 over 85, then there's a 150 in there, and then ultimately a 160, certainly we're concerned. But when you have a young patient in front of you, sometimes we just say weight loss, diet and exercise, and we move on. When you look at the coronary angiogram, it is clear that there's no, it's okay, you can go to the next slide. When you look at the coronary angiogram, it's clear that there's not any significant coronary disease after the patient makes it to the cath lab. But I think what's most impressive, if you look at the LV gram, you can see that he has this classic, what we call bird beak appearance, which you see for patients that have a hypertrophic cardiomyopathy. And this was a little bit concerning to me when I first saw this, because I was expecting this patient to have a real deal hypertrophic cardiomyopathy just based on this classic LV gram that gives you this bird beaks appearance. Next slide. And so remember, we said the patient had chest pain and palpitations, and so it's appropriate to do an electrocardiogram. And when you look at his EKG, certainly we're concerned. He's got these big, deep T-wave inversions, some ST depression. And as you look toward his anterior and lateral leads, you'll see that his ST changes are very concerning for an acute coronary syndrome. Again, we said that he presented with palpitations. And so, of course, somewhere in his workup, he had a Holter placed. While his predominant rhythm was sinus rhythm, rarely he had a few ectopic beats, nothing ventricular going on. He did have a pause of 1.3 seconds, but not anything that we needed to be too concerned about. But again, you have an abnormal EKG, an abnormal Holter, and a normal cardiac cath. Next slide. So it's hard to escape a cardiologist without getting an echocardiogram. And when we look at this echo, this is actually a stress echocardiogram. And then if you look at the image to the left, this is a 2-chamber view. The right ventricle is to the left of the screen, the left ventricle is in the middle, and obviously contrast is given right off the initial impression. You can see that the wall of the endocardium there is fairly thick, which is very consistent with hypertension. And if you look at the second view, which is in the middle there, you see that the contrast almost goes away with contractility. And so this is a ventricle that's extremely hyperdynamic. The walls are thick, and this is quite concerning for a hypertrophic cardiomyopathy. When you look at the image on the right, which is an off-axis view, but what you're looking at is the septum present in the anterior wall, you'll see that the anterior septum and actually inferior wall, that entire myocardium is thickened. The normal size on echo should be about 1 centimeter. If you were to measure this, you're almost approaching 3 centimeters. And so this is truly a ventricle that has experienced the opportunity to support an extremely high blood pressure. And you don't get these changes overnight. And so again, to further support the fact that whatever's going on to stress his ventricle out has been going on for quite some time. Next slide. And so when you come in with chest pain and you're young and we're not really sure what's going on, many times you get a CTA to make sure you're not having a pulmonary embolus. And you can see that the top left image is of a CAT scan showing very clear and open pulmonary arteries. But also on CAT scan, which is the bottom left view, you can see that, again, when you look at the ventricle, you look at those walls, they're extremely thick all the way around. And so when I see this, it is truly what I would deem as in-organ damage from hypertension or a ventricle supporting high blood pressure for a long time. And then when you go to the next image, which is on the bottom right, you see the same thing. Now, this is a cardiac MRI. And in patients that present with a weakened heart muscle or cardiomyopathy, and we think there may be a alternate cause other than coronary disease, let's just say if we think there may be an infiltrative cardiomyopathy, often we'll get a cardiac MRI so that we can get a better look at the myocardium. And one thing that we see here again is those thickened wall muscle, and you can see that there's left ventricular hypertrophy throughout the ventricle there. Next slide. And so when we start thinking about patients that present with a diagnosis of uncontrolled hypertension, I think the end organ problem that at least is most fearful for me is that these patients will progress to a heart failure diagnosis. And so what we're looking at here is a chart that represents the demographics of patients that presented to Norton Healthcare over a 3-year period. There's almost about 13,000 patients that presented with a diagnosis of heart failure. And I think the point that I want to stress is that when you start to look at the African-American representation in the city of Louisville, it's about 17 to 20%. But when we look at the folks that present with a diagnosis of heart failure that are under the age of 40, that approaches almost 40%. And when you go down and look at the chart that we have at the bottom, when it's separated by age and race, you will see that the representation for the African-American population clearly is disproportionate to the other races present. And so when we start thinking about the burden of hypertension, yes, we're concerned about stroke and embarrassed kidney function, but really what we're hoping to prevent is a diagnosis of heart failure. And again, I showed you the patient in this particular case was 37 years old. And so he would fit right in that category of having heart failure with preserved systolic function under the age of 40, which we see in Louisville and particularly at Norton Healthcare quite a bit. You can go to the next slide. So I think the takeaways for this particular case, and hopefully there is time and room for quite a bit of discussion and questions. I think the takeaways are pretty straightforward. Number one, all hypertension is not created equal. When you see borderline blood pressures, particularly in a young patient that's African-American, you should start medical therapy as early as possible. This is not a, hey, let's look at your blood pressure in the ambulatory setting, record your blood pressure and come back to me. If that patient presents to you in the office and that blood pressure is borderline, you can imagine what happens at home when that patient is stressed or that patient is exercising. That systolic blood pressure probably doubles or increases quite a bit from what you're seeing in the office. The second is clearly be cautious of longstanding subclinical hypertension, because clearly, as demonstrated by the echo, the MRI, as well as the EKG, there can be fairly significant left ventricular hypertrophy, even with what we're thinking is subclinical hypertension. The systolic and diastolic values that I gave you were not extremely elevated. However, the in-organ damage was present, again, in the left ventricular hypertrophy, but also remember, I showed you the creatinine that was a little borderline also. But if you have hypertension and you're starting to spill protein in your urine, that's another early sign that that hypertension has been going on for quite a while. And then finally, again, in African Americans, hypertension is almost always a contributing factor for heart failure. It is the #1 cause of a non-ischemic cardiomyopathy, particularly in patients that are African American. they usually present almost 20 years sooner than their non-African American counterparts that present with heart failure. And then finally, hypertension as a substrate for heart failure with preserved EF is always associated with left ventricular hypertrophy. But on the other end, if left untreated, it will progress to a non-ischemic and dilated cardiomyopathy. So move through that pretty quickly, but there is certainly an opportunity for questions, and hopefully there was some value from the case that we presented with subclinical hypertension. Thank you.
All right. Thank you, Dr. McCants. For our audience, please feel free to put any questions that you have in the chat function down there at the bottom of your screen. I'll go ahead and start off with maybe just a couple basic questions here for Dr. McCants. So what's your target blood pressure for this patient now?
You know, there's been several iterations to come out to suggest what the blood pressure should be. I still revert back to the old JNC7. I think that was one of the best guideline recommendations, although it's dated at this particular point. But when we look at what our ideal target for blood pressure should be, you cannot come up with a number without taking into context who the patient is and really focusing on patient-centered care. So if you're African American, that target should clearly be under 120 for your systolic, and your diastolic should be 75 at least. And this is obviously my recommendation, but clearly, you know, there's a phenomenon that we've been seeing for a long time now, but I'd like to get that blood pressure as low as possible in people that show you they have a substrate for stroke and other comorbidities that can affect them long-term.
Okay, so when we're looking at this presentation, how would you distinguish this from a presentation of coronary artery disease?
And so, you know, the money was on the left heart cath, and clearly, you know, playing Monday morning quarterback, the coronaries were clean. But I think the way you evaluate the patient is the same. Anytime someone presents to you with classic chest pain radiating down the arm, with that jaw pain and an abnormal EKG, you have to treat that patient like an acute coronary syndrome.
All right, we have a question from the audience here. How long would you suggest to give a medication a chance to get the blood pressure under control before increasing or adding medications?
Very, very good question. You know, for patients that have left ventricular hypertrophy, let me just start with that one. Your ACE inhibitors and your angiotensin receptor blockers are your drugs of choice. They have the ability to reverse that remodeling. But if that patient comes in on a decent dose of either one of those medicines, and that blood pressure is not optimal at that next visit, I wouldn't hesitate to start a second agent. Now, here's the problem. You get young patients that don't like taking medicines anyway, and now I'm telling you that you need two, and it may be your second time in front of a provider. And so that's where you have to spend a little bit more time doing the education, explaining what the long-term outcomes are. But if someone has hypertension in their 30s, you can bet that if they make it 30 more years, they're going to end up either on dialysis or with another feared complication from hypertension like stroke. And so it's a trade-off. I'll give you two medicines now, but I'll guarantee that you'll live longer and you're less likely to have one of those feared complications.
There's a question. Can you repeat what you said about treating a patient with acute coronary syndrome?
So any patient that comes to you as a provider or clinician that has those classic symptoms of chest pain, shortness of breath, radiating to the left arm or jaw, should be evaluated as if they have an acute coronary syndrome. And you rule that out, and then you find out what's most life-threatening first. You want to make sure that you go after that. But don't assume that it's just hypertension. Let me make sure that that's the point here. If they present with classic chest pain, rule out acute coronary syndrome first.
So if we see a patient who presents with this low-grade hypertension repeatedly, what's the tip-off to the primary care physician to either look for secondary causes of hypertension, to refer on to a cardiologist? What are we looking for?
Yeah, I think as we pointed out in the case, if that EKG is abnormal, or if, again, a simple test, if that patient's spilling protein in their urine, no one who has a normal blood pressure should be spilling protein in their urine either. And so if you have any hints of any end organ damage, that's the time to not only put them on medications, but probably have them see a specialist. Now, I want to make sure that we're talking about cardiology, but the nephrologists are excellent in managing hypertension as well. And so your referral, after you, again, have ruled out an acute coronary cause, if you need a second set of eyes to manage hypertension, I can't stress enough how important our nephrologists are in helping to control blood pressure as well.
There's a question specifically about an echocardiogram, but I would broaden that to any imaging studies. How often should we follow imaging on these patients, and what types of imaging should we be following, if any?
Yeah. And so if someone has palpitations or shortness of breath, technically you can get an echo to evaluate, and the insurance should cover it. So palpitations, shortness of breath, hypertension by itself may be a little challenging to get an echo for. You usually need that second symptom to make sure that it's covered. But if you have a clinical suspicion that something is going on beyond just an elevated blood pressure, remember in that patient's case, he had an elevated blood pressure, but we had an abnormal EKG. That's enough to get you an echo or warrant an echo. You have hypertension plus palpitations. That's enough to warrant an imaging study. And so usually you need the hypertension plus one additional concern to support ordering that diagnostic test.
But is this something that we would follow every 6 months to 12 months, or is it we just monitor their blood pressure as long as it's controlled? We don't repeat any imaging.
So the imaging piece, you get a baseline echo. If that person doesn't have a significant myopathy, there's no reason to get another echo sooner than a year. And I think that kind of the hard and fast is if there's something abnormal, yearly surveillance is okay. Unless that patient has heart failure, we tend to generally do another echo at the 6-month mark or the 3-month mark. One thing that I do want to caution against, that happens all the time. A patient may be seen in the office with an echo and the EF is 25 or 30%. That patient goes into the hospital the next week and they end up with another echo. And so always want to make sure that you don't over utilize the resources. But to answer that question fairly, if the echo is abnormal, you should at least check again after a 1-year period.
Okay. Well, thank you very much for the answers. I'm going to just admonish the crowd here that we're coming up on 30 minutes, and we certainly have more time allotted for question and answers. But if you want to answer a question, please go ahead and enter that into the chat box so we can do that. In the meantime, I'd like to thank you for attending. Thank Dr. McCants for his time and efforts to educate us today. I want to remind you that you'll receive a link to an evaluation for credit in addition to an email. And when you exit this webinar, you'll see a link to a SurveyMonkey and select the continue button for the evaluation and credit. Please join us at our next clinical review live stream on Wednesday, March 9th at noon. Dr. Lisa Folsom will present diabetic emergencies. So I would like to thank you all, and I'm going to check now to see if we have any new questions.